Okay, guys, so now we're going to talk about blood transfusion and blood products. So, transfusion therapy is to restore and maintain our circulating blood volume. It can improve our oxygen carrying capacity, and it can replace deficiencies of blood products such as coagulation factors. So, blood is infused two ways, peripheral or central. Peripheral is generally not the best choice if we have a large amount of volume that needs to be done quickly. If we are going to use peripheral, a 20 gauge or larger is placed. And so, due to the small diameter veins and peripheral resistance, transfusions on general will run slower. There is a risk of transfusions. We can have a hemolytic reaction in which red blood cells are destroyed. There's an exposure to infectious disease. And we need to remember that blood transfusions require informed consent, and many facilities now require that a patient actually sign an informed consent form for blood transfusion. There are compositions of blood. We know that we have our cellular composition, such as our red blood cells, white blood cells, platelets, and then there's the plasma composition, which is water, proteins, lipids, and electrolytes. So, blood products, we have whole blood, packed red blood cells, plasma, platelets, and plasma proteins such as immunoglobulins, albumin, and specific clotting factors. So, compatibility, this is very important when individuals are receiving blood. Our body is very particular about what blood we receive, and a type and cross match lab work is done on both the recipient and the donor blood. So the type and cross match is done with the goal of finding the most compatible donated blood for the patient. We'll look at ABO blood type, RH factor, some direct antiglobulin tests, antibody screening, as well as disease screening. Antigens simulate the form of antibodies. ABO blood types are named for their antigen. When a patient receives blood type that introduce antigens that are inherent to their inherent to their system, a reaction can occur, and these may be life-threatening. So this is just a schematic of the antigens on the blood cell. We can see with A, B, AB. I don't know if this is really what they look like in real life, but this is kind of a way to get a picture in your head of what that might look like. Mismatch of blood can cause a hemolytic reaction. This is a life-threatening blood transfusion reactions, and symptoms of a hemolytic reaction can occur with just as little as 10 cc's of blood being infused. So symptoms can include chest pain, dyspnea, flushing, fever, chills, hypotension, burning along the vein. They can develop shock and renal failure. Other reactions, we can have antibodies that attach to the surface. This forms a clot and blockage of the vessel. We can have antigen-antibody responses, which create an enzymatic protein that can destroy red blood cells. We can get an anti-glutinization, in which there's a clumping together. So we know, looking at the picture, that blood type O lacks both the A and B antigens and therefore can be transfused to most patients with a limited amount of risk. We have RH factors. So RH factor, you can be positive or negative. If you're positive, it's present. If you're negative, it's missing. Most African Americans are RH positive. This is according to the text that I used. Most Native Americans are primarily RH positive, and Caucasians are about 85% RH positive. So, two ways a RH negative person can receive RH positive: during pregnancy, when there's a mixture of when the mother is negative and the fetus is positive, and it can happen through a transfusion. This is just another thing about how blood types, such as A, B, ABO, in terms of the percentage of population. And the plus minus is their RH factor. So blood type and cross-match. So we're looking at blood typing, cross-matching, universal donors, universal recipient. So what we mean by universal donor is that someone who is O negative can give to just about everybody, which means if no matter what blood type you are, you can receive O negative blood. And if you are AB positive, you can receive just about every type of you can receive every type of blood. So there is a universal donor, which would be the person who could donate the blood, which would be our O negative person. And we have a universal recipient that can receive all blood types, which would be our AB positive. So this is kind of what our blood components look like. So whole blood. There's about approximately 500 mils in a unit. It has both red blood cells and plasma and the anticoagulant factors. So we must look at the AOB type as well as RH. Can be administered as rapidly as the patient can tolerate. We have to be careful in cardiac arrest patients. We never add to whole blood. We never use it piggyback, and we never mix whole blood with anything except normal saline is compatible with whole blood, but we don't run them at the same time. We have to remember our blood storage. So we're going to look, most blood must be stored in a blood bank refrigerator. We don't bring blood to the floor for transfusion more than 30 minutes prior to the start. We never put it in our nursing unit refrigerator. If there's going to be any delay, you return the blood to the blood bank. Blood administration, as a general rule of thumb, we attempt to try to administer the blood as rapidly as the patient can tolerate. It cannot exceed 4 hours. Generally, blood is infused between 2 to 3 hours in time frame. So then we have packed red blood cells. This particular thing, it only has packed red blood cells. So the plasma has been spun off and it is condensed. Generally, they have about 225 to 300 milliliters of volume. And we administer these over about 2 to 3 hours. Platelets, people can get platelets. This is generally there are multiple donors to create a unit of platelets. We give this for bleeding disorders. They can use to prevent bleeding in patients who have severe thrombocytopenia. AOB compatibility is not required, but it is preferred. People can receive plasma or fresh frozen plasma, which is an unconcentrated source, and it's just the plasma with all the clotting factors, but no platelets and no blood cells. So we want to help with some bleeding. We want to replace some volume, and we have multiple clotting factors that we want to think about. 1 unit of fresh frozen plasma has the same amount of plasma that would be in a whole unit of blood, but now we've separated it out. We have our packed red blood cells and our fresh frozen plasma. General volume is about 200 cc's. RH cross matching is not usually necessary, but AOB compatibility is. Fresh frozen plasma does need to be thawed before it can be given. Autologous transfusion is a procedure in which blood is removed from a donor. It's stored for a variable period of time, and then the donor is the recipient of the blood. Sometimes for preoperative blood donation, sometimes during surgery, we can save blood and give it back to the patient. We have to remember that the blood is that of the patient. Homologous transfusions are donated from another person. So usually 17 to 65. Generally, this is where their hemoglobin hematocrits need to be. Their skin has to be free of venipuncture and no IV drug use. They have to have reasonable vital signs, reasonable pulse rate, a certain weight. So what is our primary responsibility is to prevent complications. We're going to do that by verifying the order, make sure the patient understands and verify the patient and that we understand the purpose. We want to make sure the patient receives the correct blood product. We want to follow our facility's procedure, and we're going to monitor our patient before, during, and after the administration of the blood product. What are we going to need? We're going to need our protective gear, which is a mask, possibly a gown, and goggles if exposure is likely. We're going to need our tubing, pole, transfusion product. On most hospitals, run blood on a pump. We no other solution other than, and you'll see when we spike ours, normal saline can be given with blood products. Filtered tubing is used to prevent any microclots from being infused. Tubing can only be used for a maximum of 2 units, but only if those units are going to be given back to back. If there is going to be a time lag between those units of blood being given, then we will use a whole new set of blood tubing for the second unit and the subsequent ones. And we will not, although I didn't put it on there, is that if we're going to give fresh frozen plasma and packed red blood cells, we are going to use tubing for each specific blood product as well. We're going to assess the patient and the vital signs before starting the transfusion. We're going to do patient teaching. Once the transfusion starts, we're going to check our vital signs at about 15 minutes. We're going to start our infusion slowly because, as we know, a hemolytic reaction can occur with as little as 10 to 15 milliliters of the blood being infused. We're going to recheck the vital signs after the first 15 minutes according to the facility policy. Generally, these would be at the first 15 minutes, then 30 minutes, then 1 hour and 2 hours, and at the end, and then if it were to go 3 hours, then we do it at the 3-hour mark and at the end of the transfusion. But we need to make sure we understand the maximum time for the infusion. It should not go greater than 4 hours. We also need to know our facility policy as to the monitoring parameters. And what we would watch for is we would watch for fever, chills, headache, nausea, and facial flushing. We would also watch for changes in vital signs. That would be a drop in blood pressure. It would be an increase in heart rate. It would be increase in respiratory distress. So if we notice any of these, we are going to stop the transfusion immediately. We will start a normal saline infusion. We will assess the patient. We will get a new set of vital signs, and we will notify our charge nurse, and then we will follow the facility policy for blood transfusion reactions. So once the infusion is done, we're going to flush the blood tubing with normal saline. Then we're going to discard the tubing and the blood bag according to policy, and then we're going to assess our patient. So if we do, when we give blood, we're going to document the time and the date. We're going to the identification of the blood product itself, the type and amount of fluid, the volume of the blood product, as well as the amount of normal saline that was in use, the status of the venous device, the IV, before and after, all the patient vital signs that were required to be gotten during the transfusion, any patient responses, and the education we provided for the patient. So know that most complications are related to antigen antibody responses, and if a complication occurs, the infusion must be stopped. So if a transfusion reaction occurs, stop the transfusion. Generally, we send the blood bag, the tubing, and any remaining blood product for analysis. We will keep that vein open. We will assess for and document any findings. We will notify the charge nurse and or physician. We may also send a UA, and the patient may be drawn for blood to be retyped. And we will complete any incident forms that are needed to be filled out according to policy. So we talked about hemolytic as incompatible blood or improper storage. A patient could also have a febrile reaction, which is an increase of 1.8 degrees Fahrenheit or 1 degree Celsius. It's related to the transfusion. It can occur immediately or up to 2 hours after the completion of a transfusion. They can have allergic reaction. that there's an allergen in the transfused blood. They could also get anaphylactic reaction, which can occur immediately or hours after. If a patient gets a lot of transfusions, they can get an accumulation of iron pigment that is related to blood cell destruction. They may end up needing to bleed more because stored blood may lack the quality or the quantity of clotting factors. So what we're replacing in their body doesn't have the same quality or quantity of clotting factors that you would normally have in your blood. The patient could become hypothermic because blood products are stored cold, and rapid or large infusions can cause a lowering of the core body temperature, which in trauma cases and when we're going to give multiple transfusions, blood can be put on a blood warming unit. They may get hypocalcemia because of the citrate, that is a preservative that is used in blood products, and the citrate binds calcium. They could also get potassium intoxication because the red blood cells may leak potassium into the plasma. This generally occurs with large volumes of blood products, so we need to watch their potassium levels. So this is just kind of a picture about blood administration. So we're going to determine allergies, previous transfusions. We're going to give our blood within 30 minutes of getting it from the blood bank. We are never going to add any med to any blood products. We're going to identify our patient, check our order, check the label of the bag and the blood transfusion record. We're going to get our baseline vitals. We're going to make sure that we have normal saline infusing. We're going to watch for severe reactions, most likely in the first 15 minutes, our first 50 mils. We know that our blood tubing needs to be changed after 4 hours. We need to cross match this when we check it with 2 nurses. We don't warm the blood generally unless there's a risk of hypothermic or some specific, or we are specifically ordered to. Most units will run 2 to 4 hours, but never longer than 4 hours. So some transfusion reactions can occur with very little. So with all reactions, we're going to stop and we're going to maintain our IV line with saline. The patient could get a headache, increased heart rate, increased breathing, fever, chills. They could have a hemolytic reaction. They could have an allergic reaction. And that's the end of this lecture.